Well, the next paper is called Global Leaders. Actually, you wrote the editorial about this paper. If I read you the title that appears in the Lancet, you will not understand a thing. There's a title with 50 words, and I'm going to avoid it. But let me tell you how I see, and you correct me. This is a trial that I think they tried to look at whether ticagrelor alone can have an impact in patients following stenting. I think that was probably the driving force. And this study actually is 18 countries, 130 sites. And the way the study was done is as follows. First, a group was called experimental, was a standard. And the standard group is the patient undergoes stenting and then has aspirin and ticagrelor for 12 months. And after 12 months, this patient goes on aspirin alone. The dose of aspirin, 75 to 100 milligrams. And ticagrelor was actually either 90 milligrams twice daily if it was an acute coronary syndrome when they put the stent, or 90 milligrams as a single dose if it was a stable disease. This is the standard group. And then the experimental group basically is 1 month of dual antiplatelet therapy, and then they continue ticagrelor for 24 months. And the question is, what happened when you compare these two groups? Nothing. No difference. And now I can go into the primary endpoint, 2 years composite all-cause mortality, non-fatal myocardial infarction, secondary endpoints about bleeding. Each of them, there was no difference at all. And you wrote the editorial comment, Deepak. Maybe you have something to say about it, but it's interesting. I think it's a well-done study, is not correct?
Oh, I agree. I've got to congratulate the investigators. They did an outstanding job. It was an interesting question, but as it turns out, the hypothesis was wrong. That's okay in clinical trials. Well-done studies are usually, negative. And, here it's not that there was harm per se with this strategy. It's just that there wasn't any statistically significant benefit. And I think, in a sense, that's good news. As I titled the editorial, aspirin remains the global leader in antiplatelet therapy. And that's good because aspirin is cheap. It's once a day, unlike ticagrelor, which is twice a day. Few patients will have dyspnea on ticagrelor. It's not an issue with aspirin. So cheaper, less side effects, better adherence as well with aspirin versus ticagrelor monotherapy. So I think it's a win for aspirin, and we should keep doing what we're doing.
You make two comments in the editorial, which I think is looking at, I'm tired of this dual antiplatelet therapy. I'm sorry to say that, but it's like a paper every week, and it's just, but you make a comment, and that is where this field is going, and what is going, I believe, is shorter and shorter antithrombotic therapy. But I am very intrigued by the combinations of a platelet inhibitor and NOACs, because these patients have coronary artery disease, and NOACs are beginning to make noise in coronary artery disease. And I'd like to know your opinion, or at least your perspective of this dual antiplatelet therapy. You have done so much on this, but give us a capsule report of where your head is in the future.
Difficult to say, but these investigators were very unlucky. When you look at the table 3, I think in the paper, there are 20 endpoints, and none of them is significant. Even by chance, you should have 1 or 2, but none of them were significant. So the hypothesis is really not verified here. So yes, we go to shorter duration of treatments with the APT, whatever it is, except probably in very high-risk patients. And we have data out there, just like Pegasus is suggesting that we may have some benefit in some patients of prolonging treatment, especially when they have a prior MI. And the NOACs, low doses of NOACs have been tested successfully in secondary prevention. It works well in CAD patients. It works even better in PAD patients. So it works probably even better in patients with both CAD and PAD. So we will probably target this kind of patients to start off with this combination of a low-dose NOAC with aspirin, not another one. Aspirin is still there. And we will be very vigilant on safety because, of course, there is a risk of bleeding, which increases with this kind of strategy.
I am intrigued by one question about the NOACs. Dosages that we are talking about in coronary disease are pretty low. This means that these anticoagulants perhaps work at lower dose in the arterial system, versus when you have a left atrium that is large with atrial fibrillation, you need a larger dose? You think because one gets the impression that the low dose really works more for arterial disease than atrial fibrillation.
I think this is true. You want to control thrombin generation in stable patients who are living their life out there, and you don't need high doses. And we have to keep in mind that we had the same thing in the past with low molecular weight heparins. The low doses were better than the high doses.
Yeah.
So it's a repeating story.
Yeah. So, Irina, what do you think about this enterprise, ticagrelor versus?
Well, I think that this trial was inspired by two previous relatively small-sized trials, like WOOST, one of those, that found that monotherapy or taking aspirin away actually works as well as monotherapy. And with the benefit of a new generation, ticagrelor, people did expect better results, some improvement. But the trial is neutral, so effectively it may give you an idea that you could go for standard care, what you are accustomed to. It works, it's not associated with any harm compared with a different arm, or you can try and use newer strategies, though it won't be probably very convincing for many physicians and standard care. And they did actually the first month's Ticor and aspirin instead of just going for monotherapy with Ticor in the Ticor monotherapy arm. That also, I don't know what you can make out of this, but why did they design the trial in this way?
It was not a non-inferiority trial, isn't it?
It wasn't. It would be challenging, though. That's a great question. It's challenging because an open-label trial, and it has two different aspects that are different in the arms. That is, it's 1 month of DAPT in the one arm and 12 months of DAPT in the other. And in that 12 months, if you're a stable stented patient, it's aspirin and clopidogrel. And if you're an ACS stented patient, it's aspirin and ticagrelor. So there are lots of differences. And in an open-label trial, multiple differences between the two arms, I think it would be hard to claim non-inferiority. Yeah. And the challenge is, again, with aspirin, it's cheaper, easier to take, and there was better adherence in the trial to aspirin than to ticagrelor. So it looks grossly non-inferior, but they wisely didn't make that statistical claim. And again, in real life, I'd use the cheaper drug that's better tolerated, not the more expensive one that isn't.
Michael, any comment to add from a surgical point of view?
The shorter the dual antiplatelet therapy for us, the easier it makes our lives. So
he's a surgeon, kind of. I think that's
predictable answer.
It fits with you. Okay.